Hi, my name is Cecilia Carreras. I am a nuclear medicine physician in Hospital Angeles Lomas in Mexico City, and I am here to talk about what matters about PRRT. Thank you for taking me for this lecture. So, what is PRRT? PRRT stands for peptide radioreceptor therapy. And for this kind of therapy, we need two statements. The first one is to localize the receptors on the tumor cells. And the second one is to have a specific molecule able to bind to the receptors and a radionuclide at the same time. So here in the graph, you can see the green triangle is the specific molecule binding with a radionuclide, and this receptor will bind to the receptor specifically to show where the tumor cells are in our bodies. With this kind of treatment, we can see what we treat and we treat what we see. In the left side, we can see a PET-CT, and in the right side, you can see a scintigraphy after the treatment with lutetium-177 dotatate. As you can see, the same black spots in the left image are the same that in the right image, and that's the meaning that we are treating what we see and seeing what we treat. I think this is one of the most important slides on my presentation, where I will try to explain what theragnostic is. So theragnostics is compound with two words. The first one is diagnosis, and the second word is therapy. Depending what kind of element of the periodic table we are using, we can emit gamma rays, and with this we can make an image for PET-CT or SPECT-CT. Once we have diagnosed or found the cells with the expression of somatostatin receptors, we can use or change with the same molecule, we can change the element for an alpha or for a beta emitter. And with this, we can provide treatment for the patient, which will provide radiobiological effects. What kind of tumors can we treat? All depends what receptors we are looking for. We can treat, for example, neuroendocrine tumors or prostate cancer, but we have to pick the specific molecule which will bind to the specific receptor. In this color code periodic table, we can look which elements can we use for diagnosis with PET-CT, for example, with the red color, or with SPECT-CT or scintigraphy with the green color. We can also notice here that there are some elements colored with blue. These blue colored elements are the ones that we can use for beta negative treatment. For example, lutetium-177 is colored with blue. You can also see here in the lutetium square that we have also a little bit of green. That means that we can perform as well SPECT-CT, and this is very useful for dosimetry. There are other kinds of treatments like alpha therapy or Auger electrons therapy. They are colored with yellow and purple respectively. I will try to explain later in the next slide. So we have here the different kinds of emissions with radionuclides. So the first one, colored in red, is alpha therapy. With alpha therapy, we can see that the molecule is very heavy and it doesn't go very far away from the emission. And you can stop this molecule with just the skin of the patients. So for radio safety, you can use alpha therapy and is very well accepted. The beta emitters, as you can see here in the video, they fly a little bit further than an alpha particle, and you can stop it with a metal plug. For gamma, it's a little bit different because it's not a particle but a photon, and it will fly very far away from the emission point, and you need a lead for stopping this kind of energy. Here in this table is very important to notice that The alpha particles are the most lethal ones because they have this linear energy transference is very high for them because they are too heavy and very energetic, so they can kill any DNA strand in their way. Can you see here in the picture of the DNA? You can see how the alpha particles can hit a lot more than the betas, but with this, we need the crossfire from other cells to hit with beta minus particles, this double strain to kill this cell. It's very important to highlight that for betas to do an appropriate therapeutic effect, we need a high uptake of this radiopharmaceutical. Otherwise, with this, you can notice that if you don't have this double or crossfire, you will not be able to destroy this DNA chain. Very important to remember before PRRT, we need to know exactly what type of tumor you have. And that is important because sometimes the neuroendocrine tumors can have this tumor marker that the name is Ki67. And with this, we can differentiate between grade 1, grade 2, grade 3, or grade 4 neuroendocrine tumors. And for patients to receive PRRT, we really need that Ki67 is really low. Otherwise, the treatment will not be good enough, and the patient will not have enough receptors to receive enough amount of energy to kill the cells. Before the treatment, it's also important to test some laboratory thresholds because if the patient is with some issues with the blood cells, it will be some complications that we will talk about later on. It's also important to have renal and liver function tests to ensure that the patient has these organs functioning properly before the treatment. We also need to have an imaging study that the name of the study is PET-CT, and the radiopharmaceutical used to imaging is dotatate or dotatok, and it is labeled with gallium-68 or copper-64. This is also important because with this we can ensure that the patient will receive enough amount of energy or treatment or beta particles after treatment. The PET-CT is a hybrid study. It's done with something that shows the metabolic imaging and also the anatomic imaging like a CT or MR. In this patient in particular, we can see after the treatment, this was the tumor located in the pancreatic and also with some adenopathies in the near zones. And after the treatment, it was smaller and the uptake was lower as well. After this, the patient received surgery to take out all the remnants. So, in the treatment overview, the patient will receive 4 cycles of 177 lutetium dotatate, and the activity that he will receive is 7.4 gigabecquerels or 200 millicuries every 8 weeks, and each treatment or each treatment visit can last 5 to 8 hours because we need to pre-medicate the patients with some antiemetics because one of the most frequent symptoms after the treatment is nausea. It's very important to pre-medicate, and also the amino acid solutions can produce this effect. So the first thing that we have to do is antiemetic premedication. Afterwards, we start with the amino acid solution infusion, and this is for renal protection. And after 1 hour of the patient came to us, we have to start with the infusion of 177 lutetium dotatate. It's been very important to notice that after finishing the PRRT infusion, we will continue with the amino acids for renal protection. There are some symptoms related to PRRT that you must be aware. And if some patient or the family of this patient notice that the presenting these symptoms, so they have to communicate it to the physicians or nurses. It's also very important some radiation safety recommendations, and they are divided into three big groups. One is sleep, that the patient should sleep alone, no sharing beds with adults, infants, or children, and of course, no with pregnant partners. The second group is urination, or the excretion of the radiopharmaceutical via renal excretion. So the toilet should be flushed twice, and it's very important that the patient sits in the toilet. Also, as a general recommendation, distance between the patient and the public should be at least 3 meters and stay no longer than 1 hour per day. This is an example of a patient journey, and I only want to highlight the importance to notice and to know where the nuclear medicine department is when somebody has a neuroendocrine tumor, because after the first symptoms and diagnosis, all the steps further will be in contact with the nuclear medicine physicians at the beginning for staging and to grading to say if you or the patient have enough somatostatin receptors for treatment or not. After the treatment, that it could be surgery, chemotherapy, radiotherapy, or PRRT, the patient must be evaluated for response assessment, and it has to be as well with laboratories, imaging, and any study from nuclear medicine department. After the treatment, we can divide the patients between responders and non-responders, and in both cases, they will be attending regularly to the nuclear medicine department. So with this, I close my presentation. I thank you all for your attention.